I'm involved with the World Federation of Neurosurgical Societies. I have the hardest job. I'm the bylaws chair, very boring. Somebody has to do it. But I think about that as a vehicle to build community. And now all of you have more tools to build community than I ever had. You know, when I was a medical student in 1910, we had to use chisel and hammer to write a letter. I'm kidding. We had pen and paper. And but you have access to Zoom and to Twitter, and the question is, how are you going to use those tools to build community? And I think a lot. I was telling some of the students, I think about 3 communities that I think are really good for success. I think maybe you do a book on this one day. Think of your, let's say one day when you design your beautiful office when you're a big professor at Harvard or big university in Columbia. I think you should make one wall your family, one wall your mentors, but here's the wall most people forget about. One wall your mentees. I see a lot of the famous professors, they get up to get an award. Usually it's in their late 60s or they're getting out of life. They talk about their mentors. They talk about their family, their journey, but not many of them mention their mentees. And I was watching an interview of the United States Supreme Justice. And you know, one of the most prestigious jobs you can get as a law graduate is to get a job as a Supreme Court clerk. I think it's the equivalent of being a research fellow with a famous professor. And you do it for 2 years. You probably work you work like crazy. You get paid probably enough just to buy a sandwich, live in Washington. But for the rest of your life, you can say on your CV, I was a clerk with Supreme Court Justice X, Y, and Z. So don't pursue money. Pursue vision, value, and money will follow. I always say if you have a great research idea, if you have great vision, a great plan, money will come. Money is the easiest part. People think of it as the hardest part. It's actually the easiest part. If your idea is compelling, money will come. So going back to my idea about the three walls in your office, the best way to measure yourself and to build community is invest in the students below you. You may say, well, I don't have time. I have to study. But when you build that community, those junior students are going to be your biggest advocates because they're going to go to your dean and say, Daniela was such a great mentor. So when your dean writes a letter of recommendation, she's going to say, Daniela was an amazing mentor. And she has, when I've been on a committee to interview for neurosurgery, is probably one of the hardest top 2 or 3 things to get into in the US. And I've been interviewing for 20 years. I sit on a committee to help screen and get people in. And the biggest red flag we see is how people treat those below them. We had a couple of students come through to try to get into neurosurgery, and these guys had perfect scores. 272 on the AVMs, perfect grades. They saved a village in Africa on their CV. They wrote a symphony. And then we observed them, and I remember my chairman, and they would do clinic with my chairman because they want to impress, people usually want to impress the chairman. They would, oh, this person, amazing. We need to rank him high or her high. And there's a doctor, you should see how we spoke to the nurses and how we spoke to the secretary and how we treated the medical student below him off the list. So I often think, going back to the Supreme Court Justice, when they interviewed him, he showed a whole wall. He spent a little time on his family, a little bit of time on his mentors, but he had a whole wall. He had about 100 clerks later in his career who had rotated, because usually they take 2 or 3 a year. When they write those 100-page documents, they have the ideas. It's usually the clerk who's doing the writing. And he was so proud of his clerks. And in fact, they had a party for him for his, I don't know, 60th birthday or something, some anniversary. And he was so proud that they all got together in Washington to celebrate his career. He was so moved by that community. So 3 communities you think about: your family, your mentors. Don't forget your mentors. And collect mentors. Like instead of collecting, Facebook likes, collect mentors. Who's a mentor? Your co-student can be a mentor because they have something to teach you. Keep your eyes and ears open to what can I learn and what can I give. When I sit down with somebody, What value can I add to their life? Next thing you know, they're looking to add value to your life. And your mentors can be any. It could be now with Zoom. It could be some professor from Harvard who you invite to speak at your interest group. Next thing you know, you invite them to Columbia. Next thing you know, they set up a program. Next thing you know, your university has an edge over the competitors. That's life is community. And at the end of the day, your grades will take you so far. Your studying is very important. Don't get me wrong. That's the foundation. This building cannot stand without the pillars. That's your studying, your grades. If this building is designed wrong, it will collapse. So if you don't have the grades, you don't have the scholarly approach. That's not really. But this building is not the pillars. It's not the cement. It's the soul. It's the culture of your institution. It's your vision. It's your values. It's your mission. That's what will take you to the moon. When you have values and mission, the Mayo brothers who started Mayo Clinic, there were two brothers. They were private practice surgeons. They made a lot of money. They became famous, making money in northern Minnesota. You guys know the story? No? Okay. And they wanted nothing to do with the university or with building a hospital. They had an outpatient clinic, and back then they used to operate a farm. Who knows what it wasn't like it. And there was a disaster in Minnesota, a natural disaster, and the nuns who ran a convent up there came to the mayor and said, you must help us build a hospital. We're just making money. We don't have time for that. Build a hospital. We're just two surgeons. And the nuns convinced, people always talk about the Mayo brothers, actually the nuns who founded the Mayo Clinic. So women were behind it. The women founded the Mayo Clinic. It's a less known part of the story, because historically it was a bias. When women had great achievements, they were a little bit more hidden compared to men. So they convinced them, they built Mayo Clinic, and they developed a unique model that the care would be team approach. What disease do you have? Is it a pediatric kidney disease? Let's build the best team around your problem. Like you want to build the best building. You need an architect, you need an engineer, you need an artist, you need a geologist, you need a city planner. If you really want to succeed, no one person has all the knowledge. And as your dean will tell you for kidney transplant, you cannot do transplant. You could be the world's most famous surgeon. If you don't have a team around you of brilliant nephrologists, you're going to fail and fail miserably. And so the Mayo approach, that was the Mayo brothers, they said, let's do it based on a team approach. And back then, that was a radical concept. Back then is maybe what you sometimes see in private practice even today. Every doctor kept her or his own chart. And that chart was hidden and locked in my office. And if you wanted to see another doctor, they okay, good luck. Go see another doctor. This is you're my patient. This is my chart. And the Mayo approach was, let's bring it all together. And so one of the engineers who helped the Mayo brothers, because they were smart enough to put engineers in the hospital to design new solutions. So to this day, there's an engineering department inside the hospital at Mayo Clinic. And so what they did is something that sounds silly to you, but back then it was radical. If you saw the kidney specialist and your next stop was, let's say, the transplant surgeon, the chart would go from your dean by pulley. It was like they had these pulleys that would go in a bucket, and it was like a zip line. Your chart would be zip line to the next office, so that the surgeon could see what your dean said about this patient. And that sounds very basic today, maybe with electronic health records, but it was a radical concept, and that really propelled Mayo Clinic in a very big way. When they retired, soon before retirement, I think, they gave away all their wealth to the Mayo Foundation, and they took a modest salary. And they were the two most famous doctors in the world. And that act is the only reason why Mayo has lived, because they started the foundation not based on money, not based on profit, but based on this team concept, innovation, always thinking about how do I move the field forward, and the idea that everyone at Mayo Clinic gets paid the same within your specialty. So you don't pay more if you do more surgery, so that we don't bias and say, I got to do more surgery this month because I have a payment for my boat or my. So we pay people competitively at Mayo. That's a very unique concept. Even in most of the United States, we won't see that. So anyway, I don't mean to be an advertisement for Mayo, but give you a sense of the culture I come from, and I want to learn more about your culture, just to give you a sense of that. So, oh, we have this resolved, okay. So maybe with that background, let me talk about a disease I care very much about. That's brain arteriovenous malformations. It's a very interesting disease in my view, and for me, because it's an important cause for several reasons. One, it's an important cause of hemorrhagic stroke in the young. So the overall picture of stroke, it's a very small, driver. But if you take stroke in young individuals, so if let's say a 32-year-old medical student comes to the ER with a brain hemorrhage, that's an AVM until proven otherwise. A 90-year-old who comes with a hemorrhage to the ER, it's probably amyloid angiopathy until proven otherwise. Why is that important? Because you affect the human population at a younger age. It is a cause of disability and death in the young individual. You take a young mother or a young medical student, versus if a 90-year-old has a hemorrhage, that's also, we care about everybody, but it doesn't have the same impact on a family, on society. It's a treatable cause of stroke. And when somebody hemorrhages from an AVM, if they're lucky to survive the first hemorrhage, it can be treated to prevent another big hemorrhage. So those are some of the reasons why I care about AVM. One other reason, I love a team approach to healthcare, and this disease is a great model for team care because you need to do this well. If you want to set up an AVM center of excellence, you need neurosurgeons, you need neuroradiologists, you need interventionists, you need radiation therapists, you need psychologists, you need brain mappers, you need neuroanesthesiologists. You need a big team to do it well. Epidemiologists, if you want to do the research. So if you're not even talking about research yet, you want to talk about research, you need genomics, you need a lot of things, artificial intelligence, etc. So what I'm going to talk to you about is how many in this room have studied AVM, or heard about it, heard about it a little bit. Have all of you at least heard a little bit about AVM in your studies? I'm sure it's come across your desk. But probably in the sea of things you have to learn, it probably has occupied a small percentage of what you've been exposed to. So don't worry about knowing everything I'm going to talk about. What I hope to offer you today is just a little bit of insight to how a surgeon who's been doing this for 20 years thinks about this disease. And maybe it'll offer some of you in the audience ideas for how you want to approach the diseases you will treat. Because if you want to be the top of the game, if you want to become the top person in the world for the disease you treat, you need to build a team. You need to ask yourself the question, how am I going to advance the care of this disease in my lifetime? And how am I going to do it? What team do I need to build? And what are the problems? Because if you don't understand the disease, you don't know what the mother of invention is understanding the need. And the best foundation for research is knowing what the knowledge gap is. Where is the problem? So that's the hard part. Most people just say, well, I like molecular biology or I like artificial intelligence and I want to improve stroke care. But the first part you have to do is understand what is the need, where are the needs to improve before you even think about the tool. And that requires discipline and study and depth and mentorship and so on and so forth. Let's talk a little bit about AVMs. Again, I'm competing with the beautiful Bogota weather. And I'll try to not put you all to sleep, but we'll try to have a discussion. If you have any questions along the way, please raise your hand. We can make this a discussion or just a straight lecture, whatever you prefer. So this is our hospital in Mayo, Arizona. I have no financial disclosure. It's very important whenever you give a talk that, I don't have any research funding or anything related to this. I have biases. Every doctor is biased. And if any doctor says they're not biased, that means they're not human. They may be an AI system. But even AI systems are biased for whatever data you put into the AI system. I do fear harming my patients, so I have fears. I'm a Homo sapien. This is from a couple years. This is pre-COVID. Our department is probably twice the size now here at Mayo, Arizona. And this is our AVM team. On the procedural side, I have two partners who are back home. And I'm fortunate that you need partners because if you're going to be the top of your game, you need to be able to leave town sometimes. You need to spend time with your family. So it's important to have a team. Dr. Krishna, Dr. Turkmani, Dr. Chong. We also have great stroke neurologists who back us up. A wonderful team of stroke neurologists who are very important to help us and to collaborate with us. We have a fantastic group of neuroradiologists. These are people I sit down with and think about the imaging with and so on. Very important. So We have every morning we have a conference, which you're all welcome to, by the way. And we always like to have radiologists with us. They're our navigators, so to speak. Radiation oncologists, I think it's an unfortunate misnomer. Whenever I tell my patient with an AVM, I need to see a radiation oncologist to think about your disease. Do I have a cancer? So I think it's a strategic error for them to be called a radiation oncologist, although there's some advantage to them, of course, to have some foothold in cancer because AVMs is not a cancer. But we do use radiation for select AVMs, so we collaborate with them. We have a unique brain mapping team. So what is a brain mapping team? So Dr. Baxter is a psychologist who specializes in functional MRI. And Irina Mizika is a neurologist who specializes in brain mapping in the operating room, but also in the preoperative understanding. So neurology, psychology, neurosurgery, all coming together with neuroimaging to map the brain. And I'll show you in a little bit why that's important. We have our stroke coordinator, Vanessa Vanderhei, monitors our data. If you want to have the best kidney transplant in the world, you need to have a team that's monitoring your data and comparing your data to national benchmarks, international benchmarks. It's no longer okay to say, well, we're the best. Those who are the best always say we can improve. And you can only improve what you measure. And the question then becomes, how do you measure? And how do you sustain improvement? And how do you create a culture that is driven by a desire to improve and a humble confidence around that, rather than an ego that is very fragile. Beware of fragile narcissism, which doctors will have big egos, and sometimes it's fragile. The worst combination I think is fragile narcissism, because oh, well, doctor was that an infection? No, that wasn't an infection. There was a little redness on the skin. Well, you need to be objective about these things. These are my dear residents. We have a new residency in Mayo, Arizona, Dr. Hudson, and all three of them so far, and actually still top secret, but now for the fourth year in a row, we're getting our top choice. So we built a great, Evelyn Turcott, she was my research fellow, and she's now on her way to Mayo Medical School. She's a fantastic, if you want to know anything about Mayo Medical School, or she's a great resource to you. So our residents, again, community. My goal with residency is not just to, I don't want their best day to be the last day of residency. I want it to be a happy, sad day, because the way universities are starting to think about, and I think your dean would probably agree with this, we don't think of graduation as the end. We think of it as the beginning of a lifelong relationship. And I can give you a whole talk on that concept. And we want our residents to be a part of a lifelong community. Half our residents stay at Mayo Clinic, by the way, so we have a vested interest in making sure they're the best of the best before they come and while they're there. And then if they're going to leave, they're going to be, if they come and practice in Columbia, well, they're going to be our ambassadors. I can't have a graduate from Mayo Clinic come to Columbia and be regarded as a horrible doctor. That would be very bad for us. So we are really invested in creating the future by investing in people. So I'm going to talk about some commonly held beliefs. I like to, and one thing I would encourage you to do, dig deep on knowledge. The problem with your generation has more access to knowledge, easier. Your dean and I, when we wanted to look up the papers, we would get lung disease sitting in going to the basement of the library, and printing. I used to have to load a cash card to use the printer. And now, one press of a button, you have access to papers. But the problem is, I worry that it's become so easy, it may keep some of us, including me, from digging deeper. They always say, if you want to learn something new, go far enough back. So it's very important, if you want to know anything, to really understand the history of where the knowledge came from. There was one piece of news last year where, in the COVID pandemic, there was, and I don't understand this issue very much, but there was a widely held belief about how viruses spread that was based on one paper from 1970. Nobody questioned. It turned out to be completely wrong. And so what is knowledge? And how do you assess knowledge? So learn statistics, learn to be critical of literature, and question. It's okay to question. Sometimes it's good to question and keep building your knowledge. Knowledge is not written on a tablet. It's something that it's a living, knowledge is a living organism. A quick story about Warren Buffett. Warren Buffett, Warren Buffett, most successful investor in history. He had read every book in his hometown library at age 9. His father had to get him books from Washington. He reads 8 hours a day. Knowledge is power. He will not buy a stock unless he knows enough about the company to buy the whole company. And that's why he's the most successful. Most investors are like, ah, that's not, yeah, Apple sounds good. You know, they're selling a lot of iPhones last month. He won't buy Apple unless he knows where their vice president sits. And what do they add to their coffee in the morning? You know that. So the idea is that knowledge is power. When you have knowledge, and not just rigid knowledge, but dynamic knowledge, where you say, the more knowledge you have, the less I know. My feeling of not knowing anything keeps growing every year. It scares me. I feel like I'm becoming less knowledgeable. I don't think it's dementia yet. So, but I do feel a humility about my knowledge. I know nothing. And then it creates a hunger for me that I have to read, because I have to compete with my residents. I have to know more than them. So I have to read before conference so that I know a little bit more than them. Otherwise, you know, you fall behind. So what is an AVM? An AVM is a congenital lesion, usually congenital, that is an abnormal connection between arteries and veins. As you know from physiology, arteries go to smaller arteries, smaller, until you get to capillary. The arterial pressure from the heart pushes blood through the tissues to offload oxygen and nutrients, you know, and then goes into venules and bigger veins and back to the heart. That's my simplistic neurosurgery understanding of it. What an AVM or a fistula is when the blood flow, the blood bypasses the tissue. What does that do? It reduces that pressure sunk. So usually the tissue absorbs a lot of that diastolic pressure. So by the time you get to the vein, you're at 10 of pressure, whereas normal blood pressure is 120 over 70. You need that gradient, but it pushes through the tissue, and then it goes. But with an AVM, there is no that barrier. So arteries are going through an abnormal connection of arteries. So what does that do? It creates a venopathy. So veins don't like to see arterial pressure. We do it sometimes therapeutically in nephrology with a fistula, a human-made fistula, but usually veins don't like to see arterial blood. Veins start to constrict. They can rupture. They can form aneurysms. And so that's one source of a problem. The other source is a tinnitus, this abnormal connection of let's call them abnormal capillaries or capillary-like vessels. It's like a spaghetti of abnormal capillaries that can blow up. The other thing that can happen is what happens with abnormal hemodynamics in the brain. If you have too much flow, you can get aneurysms. So 20% of patients with an AVM also have an aneurysm, whereas in the general population, it's about 1%. This is just a cartoon of, but keep in mind the cartoons are easy. These are very diverse lesions. You know how they say with snow, do you see snow in Bogota a little bit? Not too much, or not at all. You're pretty high, but well, I grew up in the Midwest, so we saw a lot of snow. And if you look close enough, no two snowflakes are alike. To an alien visiting Earth, to me, all mice look the same. I don't spend much time with mice, and I never did animal research. But an alien coming to visit Earth, you would all look like the same. But the more you look closely at somebody, no two people are alike. Same with AVMs, they're all very different. They're different in their size, location, their relationship to surrounding tissue, whether they have an aneurysm or not, are the veins surrounded, etc. The incidence is about 1 in 700. 11% of all vascular malformations. 64% are diagnosed before age 40, which every year to me looks younger and younger. So there is when an AVM bleeds, there's a 13% of patients that are moderately disabled, so it's a cause of disability. 3% of patients are severely disabled, meaning they have to go to a nursing home. And there's up to a 50% chance of neurological deficit that may or may not improve after a hemorrhage. And 10% mortality. I think that may be an underestimate because people who just collapsed at home and died may not be counted. So I suspect, and AVMs in the back of the head, like cerebellar AVMs, the mortality is much higher. So how do they present? Hemorrhage is the most common presentation of symptomatic patients. Increasingly now with modern imaging, if you have a little itch behind your ear, you get an MRI. So many people are being diagnosed incidentally, which is one of the challenges of modern medicine. They can cause seizures. They can leak blood to the surrounding tissue. And that hemosiderin stain is a driver of epilepsy and seizures. Mass effect, they can get big and cause pressure. They can cause headaches. Bruit, you can impress your dean or your faculty if you go to the ER and you listen to the head with a stethoscope and you hear a bruit, that could be a sign of an AVM. When an AVM gets big and it's starting to steal blood from the surrounding tissue, that can affect that tissue either by causing seizures, neurological deficit, etc. Incidental discovery is becoming, as I said, more common. And cognitive impact has been very poorly studied. So if any of you are interested in PhD, I've seen many people with AVMs because of the hemodynamic effect, or maybe their brains are wired differently. They may have some cognitive, developmental cognitive or cognitive issues. But it's not well studied. In kids, AVMs can cause hydrocephalus with macrocephaly, congestive heart failure, prominence of forehead veins. I had once a patient who was an ER doctor in Chicago who had a fistula behind his ear, and that's the AVM of the dura. So it's a different cousin of the brain AVM. I won't talk much about those today. When he was a child in India, the kids would come up for fun and listen to his head. So he was known as the kid with a noise that they could hear his heart. You could just stand next to him. You know. So he presented to me. He was an ER doctor in Chicago with progressive cognitive decline. His AVM was stealing more and more blood. Never caused a hemorrhage, but it was robbing his brain of flow. We did an embolization procedure. His cognition came back. I saw a CEO who had a fistula to the back of the head, draining into the internal cerebral veins. And he was diagnosed with dementia. He was a 45-year-old CEO. I mean, 45-year-olds who shouldn't have dementia. He was having venous hypertension in both thalami. And for those of you who enjoy studying neurology, there is a syndrome in neurology where you have bithalamic dementia. If you get strokes in both thalami, you can forget about your cognitive function, or it's going to be affected. Posterior fossa AVMs, cerebellar AVMs, unique category. There are 20% of AVMs, and these are more morbid. If you have a hemorrhage from a cerebellar AVM, I've saved some of them, but you have to act fast. You need to act like a fire department. And if you get them to the OR fast, you can save some of them. So an AVM is a very unique entity in that it's not just a structural entity. This is not, I was very simplistic when I said arteries and veins, and it's actually, there's inflammatory things going on when you have high flow like that. So there's ischemia that's running tissue that can drive potentially VEGF, things that can cause neogenesis. Hemodynamic stress, which has the effect I alluded to, and angiogenesis. These are issues that we don't fully understand. When it comes to advising patients about surgery, there are many scales, and one of the simple scales looks at the size of the AVM, its location, whether it's in quote-unquote eloquent brain versus non-eloquent brain, which is a misnomer, by the way, and then whether it has deep venous drainage or not. And you can then create a score for the AVM. If you have a high score, it's not a good case for surgery. If your score is 1 or 2, you have a great outcome from surgery. 3, it's a mixed bag. 4 and 5, I would be careful with those. You want to think about radiation or observation. If they're symptomatic, you can think of some other strategies that we can talk about. So we need to be smart about who we treat and why and how. Just because of time, I'm going to skip over. I have a series of slides. There's a randomized, poorly done study, if I may, done on looking at no treatment versus treatment for AVMs, the Aruba study, consumed millions of dollars from the FDA. You're going to tell I am biased. But I would love, actually, we could, if you would like to get together again, I could give you a whole hour of how not to design a clinical study. But in this study, they compared any treatment for AVMs compared to medical management using what I would call a embolization heavy strategy. I use embolization every week in my practice, but this was sort of an embolization first strategy, and their complication rate wound up being higher than observation. This is for unruptured AVM, so we're talking about a subset of AVM. But it's important to know this, and this has led to us to rethink how we manage AVM. And these were 2 Lancet papers, and basically they compared treatment versus no treatment. Very unique, unusual study in that they compared any treatment to no treatment, which would almost be like in hypertension, comparing any drug you want versus no treatment, what's better. And so it was a very difficult study to embrace, so to speak. And no treatment, and the follow-up was only a couple of years. When you have a disease like AVM, the risk of rupture on average is about 3% per year, 2 to 3%. But it's a very heterogeneous. So some AVMs may have a 30% risk of rupture. over per year. Some may have 1%. And they only follow the patients for about 2 years or so. So it's almost like telling, the equivalent of this would be taking a bunch of college students, having them smoke for a year, and then doing CT scans of their lung a year later. You're not going to find any cancer. So you have to understand any disease, you have to understand the natural history, going back to what I said earlier. And this is just, I'm going to skip over some of these a little bit just so we can get to more interesting parts of the talk. And what was interesting in this study is that about 80% of their AVMs, remember I talked about the grading system, how grade 1 and 2 do very well with surgery? In this case, only 5 patients were treated with surgery. The rest were treated with embolization and radiation. So it was a bit of a mismatch. In fact, most North American centers did not participate because we didn't like it. But right now, what happens is this is the only randomized study published, so it does affect how some doctors think about the disease. So let me just, again, I'm going to skip this part because just to be respectful of time, and let me move on beyond this. So I'm going to try to talk about a couple myths. They may not be myths to you yet, but I'm going to use this as a platform to help you think about, don't believe everything you hear. Even in medicine, there's such thing as fake news or pseudo fake news, and I think it's important to go to the source. You know, no study in basic science, no study is believed until it's produced in a different lab, right? I mean, we don't think of it this way. We always we're quick to celebrate. You know, remember that stem cell lab in Asia? Nothing against Asia, by the way, but where there was a lab that published on stem cells have solved. Nobody could reproduce the study, and so they had to retract it. Eventually, they found out that there was some funny business going on in the lab. So a randomized study, equivalent in clinical research, is that a clinical randomized study alone is not enough to make guidelines. You need 2. That's what ultimately gets you the highest level of evidence. So if you have 2 different groups, one in Paris and one in Colombia, doing a randomized study, they both come to the same conclusion. Now you can do a meta-analysis. If the meta-analysis comes out positive, so this is the story of how do you develop knowledge. On the other hand, there are things that cannot be subject to that. For example, there will never be a randomized study. This is kind of facetious, but you may have seen this cartoon. There will never be a randomized study of whether to use a parachute jumping out of a plane. That will never. There are certain diseases that are so bad that we will never randomize. For example, basilar artery occlusion. We know the outcomes are so good from embolectomy, and the outcomes are so bad from medical therapy or medical therapy alone that no one is ever going to randomize it. But that doesn't mean we don't study. It doesn't mean we don't. There are alternative methods. And I was so interested in this. Like after I was done with residency, after 52 years of training in medical school, and another 7 years of neurosurgery. But I always tell my residents, sushi chef in Japan is 12 years. Neurosurgery is only 7 years, so it's a bargain. I got a master's in clinical research. So never stop learning. Never stop. And you do it one night a week, and I'm taking courses on Coursera now in artificial intelligence because I want the last day I learn to be the last day I live. Because you always can learn new things. And so here's a myth. I was taught in medical school by great professors that AVMs are embryological. And yes, most of them are, but not all. So there's a bunch of literature. They can occur post-radiation. They can occur in association with a disease called moyamoya disease, sickle cell, band heterotopia, and trauma can lead to a fistula or an AVM. So question all knowledge. Here's another one I love to talk about. AVMs are static and they don't change. You're born with an AVM, it stays this way for life. Well, then why? That used to be the common knowledge accepted worldwide. Then why do they suddenly rupture at age 30? Either you're born with it, or why didn't it rupture at age 20? So it relates to a bias, a human bias. We are biased by what we see, by what our senses tell us. So when you look at a mountain, what's the symbol of no change? A mountain. It's a symbol of eternity. It's a symbol. But a mountain, if you have a geologist, will tell you it's changing every minute. A mountain, take a picture of a mountain in Colombia today compared to 100 years ago, and they have a different altitude and erosion, etc. But we think of a mountain as a symbol of pretty much changes. And when you get an MRI and an AVM, let's say every year or two, let's say you decide not to treat AVM, and I observe many AVMs, we don't treat all of them. The neuroradiology report will say no change. but are they looking at the molecular changes? No. Can they see venous stenosis well on a certain MR? No. Can they measure the pressure in the veins on an MRI? No. Can they look at these tiny aneurysms that form in the ibis in an MRI? Probably no. So we call it unchanged. We tell them, oh, great, it hasn't changed. That may be the simplistic, and sometimes it's appropriate to say that, because sometimes some people are nervous, but sometimes knowledge has many layers. It's like an onion. The more you peel, so they are not static. So this 12-year-old had a seizure. This was when I was in Chicago. And he came to the ER. They did an imaging. They had this MRI that showed an AVM that would very, I would forgive any of you if you missed it. It's a tiny AVM here in the premotor area of the brain. And I hadn't met him at that time. We saw the pediatric team, and they recommended radiation to this, which was an appropriate option. Surgery is also an appropriate option. Embolization could be an appropriate option. But he got lost to follow-up. Didn't follow up and had a seizure. They said, no, we don't want radiation. Radiation scares people. And so and then so got lost to follow-up. Some of you may be struggling to see that AVM. It's so tiny. See here? On this screen, it's really tiny. And so there it is. Sorry, these images. Okay. So then he comes back to see me 6 years later, because he had another seizure. 6 years later. Okay, age 18, comes back with a seizure. Now can you find it? And I said, wait a minute. I thought you told me AVMs don't change. They do change. We just, think about it, how long has MRI been around? In the old days, to diagnose an AVM, you have to have an angiogram. Are you going to get an angiogram every year? No. So before that was air encephalography. And, so modern MR and the repeated MR has given us windows, so they're not static. And this is now a sizable lesion, has a hemorrhage, by the way, it's called a seizure. And I'm going to come back to this case a little bit. So as I think about AVMs, the real trick in my trade, and actually this is true of almost anything you do in healthcare. We don't think of it this way always. Always, no matter what specialty you're on, even if you're recommending a cortisone cream for the skin, a good doctor is always balancing risk versus benefit. There's natural history, and you're competing, hopefully with the patient as an ally, with that natural history. And you're weighing the risk and benefit. If, for example, if somebody has a bad kidney disease, and you're going to put them on powerful immunosuppressants, you have to know what the natural history is to justify the risk of immunosuppression. Same with my surgery. I mean, neurosurgery, my God, that's, my field has a reputation of being barbaric. Get a craniotomy, open the skull. I mean, you better have a good reason. And so if you don't understand the natural history, you should go back to the library. You shouldn't be in the OR. You have to know what that disease is going to do. Otherwise, you're not making good decisions. How can you make good decisions? And so one of the things that my lab does is to try to think about, remember the brain mapping team? So I'm always navigating natural history. What's competing with natural history? The risk of treatment. What is risk of treatment in my field? Well, how big is the AVM? Where is it located? The AVM in the middle of the brainstem? You're not going to do surgery on that. Maybe radiation. Is the AVM sitting up here? Well, that's easily accessible. But how big is it? And was it symptomatic? Does it have an aneurysm? So one of the things we think a lot about is we tend to think about brain mapping. What the medical school is the motor area. There's the speech area. There's the sensory area. Everything else is just hard terms and things that are just you have to memorize. And so in my field, the frontal lobe was labeled non-eloquent, meaning, what is wrong? Oh, God, cut it out. What is it? But that's another thing I started to question. You could argue that the frontal lobe is the most eloquent piece of tissue in the universe. The frontal lobe, I like to study comparative anatomy. You go to the historical, the Museum of Natural History, there's huge animals, but they have these amazing structures, amazing biology. None of them have a frontal lobe. Very little frontal lobe. Even there are animals, by the way, with a bigger brain than we do. I think one of the whales, sperm whale, I think, has a much bigger brain than humans by volume, by weight. But as we all know, it's not just size that matters. How many we have the most connections in the brain. about 1 trillion neuronal connections. Mammals do much better than reptiles. Reptiles have very, very little, eat, drink, and hunt. There's like a couple functions there. But I'm degrading the reptiles. Sorry, I do study reptiles a little bit, and they are more sophisticated than that. In fact, this is how far our brain mapping is done. We actually looked at comparative. I study music in my lab, and I'm on a symphony board in Phoenix. And it turns out that alligators diverted from mammals hundreds of millions, long time ago. An alligator, if put in a functional where I can distinguish between Bach and randomizing those notes. So even in the reptilian brain, there is fairly sophisticated when you look back at the bigger picture. Anyway, so how can we better map the brain so we can be more sophisticated? Because one of my inspirations for this, I had a pianist in Phoenix, and she told me her AVM was sitting in quote unquote Wernicke's area, right in the left ear. You don't know Wernicke's there. Wernicke is the most feared area of the brain because if you don't have Wernicke, you can't understand anything. It's horrible. She said, if I can't play the piano, I might as well be dead. That was her life and passion. If my leg is weak, no problem. If my arm is, if I can't talk perfectly fine, but if I can't play the piano. So now we try to understand what people do so we can map their brain based on that skill so that we can individualize the map and create an avatar of the patient that is unique to their care. We now create an avatar for every patient on clinic, by the way. So this is the AVM I showed you, the 18-year-old. So you have to ask your question. We know this AVM, now that it's grown, it's caused a seizure, the risk of this AVM to him, conservative estimate, 3 to 4% risk of hemorrhage per year. Factor that out over a lifetime, the odds are much greater than not that this AVM will hurt this individual in their lifetime. And it's not a very big AVM, so surgically this is not monumental, but this is the motor area sitting right behind the AVM. So if you're going to treat this, you have to be respectful of that. And this is the hand function is right in front. Most of us like to have use of our hands. By the way, you also have to think about it. If this AVM were to hemorrhage, it could also affect the hand. So there's two sides to that story. This is the hand function again. And this is a synonym test. We start to map speech. Synonym test there on the left side. And then we can do something called spectral imaging. So what you saw before is functional imaging, where if you move your hand, the motor area lights up based on oxygen use. But this is actually looking at all the much more interesting story. What are the connections in the brain? And here in 3D, we can see the corticospinal tract. Because if I'm going to be a pilot navigating around the AVM, I need to understand my no-go zone. What is the no-fly zone? It's a common thing in the news today. What is the no-fly zone? So this is my no-fly zone. And I need to visualize it, not in 2D, but in 3D. So we can actually put this in a virtual simulator and we can walk through it. I wish I brought it today. If you come visit us in Phoenix, we'll show that to you. We have a system where you can put this data and we can walk around the corticospinal tract. And at surgery, we need to see the augmented reality of that tract in our field and then simulate the tissue to map the tissue electrically. Because you can interrogate something based on imaging, but you can also prove it. If the patient's awake, for example, I can simulate those tracts, and my neurophysiologist sits with me in the OR. The same mapping team that saw the patient in clinic also sits with me in the OR. And they can then tell me how close I am to that corticospinal tract. And it's a very simple thing. I only took one physics book. I'm not a big physics guy. 10 milliamps on my instrument is 10 millimeters away. 1 milliamp is 1 millimeter away. So somewhat simplistic, but we have electrical ways to dance with the brain to tell us where we are. So this is another AVM. So this is 4D. Forget 3D. Let's talk about 4D. This is flow. So we can now with 4D MRI, this is a massive AVM compared to the other one. If we're going to tackle this, we have to dry it up with embolization first. But how are you going to do it? Which feeder should you go after? Red is higher flow, blue is lower flow. Can we be certain? We've published on ways to strategically devascularize the AVM, trying to use this data to guide us. This is just some of our papers that we published. What about the fifth dimension, the biology? So this is from a friend of mine in Chicago who studies molecular MRI, where you can tag antibodies to something that you care about, and you can light it up. So what if one day in 10 years, one of you geniuses does a PhD on an inflammatory marker that distinguishes AVMs that will rupture versus those that won't rupture? That'd be useful. That would be useful in my clinic. So third myth, you're going to memorize a lot of things in medical school that this disease has a 1% annual risk of hemorrhage. But a smart statistician knows that any number you read in medical school and literature is, where does that number come from? It's an average. In fact, you can study modern medicine, well, PREMA is basically a study of averages. On average, this patient does this, and on average, we can help him. So then you have to do a regression to the mean, because we all have the risk of just starting to believe that the mean is everything, but there's a spectrum. And are we sophisticated enough to distinguish the patient? You know, because we look at the patient not as an individual, but as a sample from a population. That's what all statistics is based on. So yeah, that's okay. It's better than what we had before, which was sorcerers and witches telling us, well, it's better than what we had 200 years ago, but it's still not the end point. I want to know in my clinic, not how Daniela will do compared to 1,000 other patients who may have nothing biologically similar to Daniela, but how will Daniela do? And that's where artificial intelligence and bioinformatics will start to play a role in how we decide on decisions. Because when a patient comes to see you, they're not asking, so if you have a study that on average, this patient will do this well in 5 years, when somebody brings in their daughter who's 25, they're not asking, doctor, is my daughter going to be okay for 5 years? That's not what they're asking you. They're asking you, what does this mean? Is she going to live to be a grandmother? Our literature, how often have you seen a 30-year follow-up study in literature? A randomized study because the NIH won't fund that 30-year study. Nobody has the attention. Human beings are mostly, our attention span is about 2 to 5 years. So, most people want to go on to something else. And there's no funding for long-term studies. So this is from one of our reviews. So how do we get to that bioinformatics or artificial intelligence driven? I want a robot in my clinic that, makes my coffee and then, helps with decision making. Hey, Siri, how did 1 million patients do load the data from the patient, do a blood sample, look at their genetics? We as physicians are very binary in our thinking. We think of humans good or bad. Many humans by something like communists. We're like Republican or Democrat. We can't handle third party. That's too much for a party. You're either communist or you're a capitalist. Well, the truth is actually a spectrum. But when we are young species living in the forest, that I don't know good or bad. Is this plant poisonous or not? It's a very adaptive way to think about the world. It's not the truth. So these are factors that increase risk of hemorrhage. So if we should have fire hemorrhage, that's a big driver of another hemorrhage. Bad distance, we get so predict badness. If you have an aneurysm with your AVM, that's a big bad behavior. Involving the perforators, deep respiratory location that we talked about, deep location, deep venous radius. These are things that drive higher risk of hemorrhage. These are more controversial on the right side. So this is just my graph about, these are my residents, the history of healthcare, like in one slide, the Hippocratic era, where a lot of our values stem from that era. Louis Pasteur, the scientific era. We don't believe anymore in witches and shamans telling us that. And then right now we're still in the era of population science, by the way, which comes from agriculture. So randomized study science comes from agriculture, which is another interesting story. But now you are going to be the champions of precision medicine. And you're not going to be able to do it alone. You're going to need a team. You're going to need engineers. You're going to need bioinformaticists. You're going to need statisticians. You need artificial intelligence. You're going to need a different way to design how you're going to practice. And you need to be plugged in. The idea of a doctor functioning alone in an office, that's historical interest. So let's talk a little bit, how are we doing on time? Are we okay? Should I spend a little bit more time on treatment, or do you want me to break it up and we do this another time? I will take your lead. Okay, you tell me. Okay. So let's shift. Obviously, I'm a surgeon, so I like to treat. So, as I said, I probably observe more AVMs than I treat, for what it's worth. I treat a lot of AVMs too, but and let me say something different about my training. So when I grew up, my mentors trained in either surgery or endovascular embolization or radiation. I've tried, actually, one of my key messages today, I've actually, in my career, I'm one of the few surgeons in North America that has integrated all three. So I did an endovascular fellowship. I spent a decade with one of the pioneers of microsurgery. By the way, a fellowship is only a stepping stone. Fellowship gets you into the lobby of a beautiful building. If you want to become the best of the best, you want to be like your dean and be top of your field, it's a lifelong learning, lifelong education, lifelong mentorship. One of my mentors, the endovascular mentor, told me every year visit one doctor, go to a center, and the more remote they are, the more quote unquote developing country they are, the more creative they're going to be. So yes, visit the Harvards, visit the Mayo, but also visit that center in Malaysia. That center, best week of my life clinically was I went to the NATO hospital in Bydgoszcz, Poland. They set up all these cases for me and my ENT colleagues. Massive tumors that we would never see at Mayo Clinic, because in America, again, if you have a little headache, you get an MRI. These two are delayed diagnosis. And by the way, the hospital was walking in 1950. This is soon after communism. Great team, great nurses, great doctors, but their knowledge froze. And it's not a political statement, by the way, just a factor of what was happening in our country. And so the amount, but even though their knowledge was several decades behind, they had to be very creative. They didn't have our instruments, they didn't have our tools. You know, Mayo Clinic, I'm spoiled. I can use a one stitch for every, you know, I got one stitch for every layer in Bydgoszcz. You got the nurse said you only have 2 stitches to close. Anyway, so it pushes you to be creative. So being in a less impoverished environment makes you better. You can learn more. Sometimes when you're working at a Mayo or a Cleveland clinic, you get a little spoiled. I mean, you've got a subspecialist for, you know, for the right kidney versus the left kidney, you know, so you get a little spoiled, and that's not the reality of it. So spend some time on global health, but not just for the benefit of the recipient. The biggest recipient of outreach to developing countries, if you're in global health, is not them, it's going to be you. The goal is a humble learner or student. Endovascular treatment. So endovascular treatment is many, many different things. You could spend a couple hours just on this. You can embolize an AVM with coils or glue before surgery to make it smaller, to make it more operable. You can target a rupture site. Last week I admitted a patient with an AVM that had casted the ventricle, 95% mortality. We found the rupture site, I sealed it, then we started TPA in the ventricle. Blood completely cleared. And just today they told me they pulled his ventricular catheter, he needed a shunt. So we took him from 90% mortality with that hybrid approach, dropped it down to maybe 10%, maybe. Securing of a proximal aneurysm is another area. Embolization for cure in some cases. Before or after radiation can be an indication. Palliative embolization. Sometimes people have dural headaches. Let's say you have somebody with a grade 5 AVM, dural headaches. Embolizing the dural feeders could be a way to treat the headache, even though you can't cure the AVM. Venous stenting, believe it or not. I had a violin player once who developed a Chiari from her AVM because she had venous hypertension. And we were so focused on the arterial side, we actually missed it. Until she almost went into a coma. And went back and looked at the angiogram. She had occlusion of one intraocular vein, stenosis of the other. We popped it open with a stent, she woke right up. And the Chiari reversed. We actually wrote that out. It was a cool case. Embolization before radiosurgery, complicated topic. The bottom line is we don't believe in it. It's controversial. What about, this is one of the reasons that led to the Aruba study not doing well. There was a pattern in Europe, a different school of thought, that you could take these complex big AVMs and just every year embolize them a little bit. It turns out that you're worsening the natural history. It's actually a lesson for all of us. Sometimes as doctors, we think we're helping, but we actually may be making something worse. So beware of, you know, to do no harm, back to Hippocrates. So this actually just shows that you could worsen the natural history from this. What about embolization for cure? I think only about 5 to 10% AVMs can be cured with embolization. So which AVM? This was a 71-year-old gentleman with pulmonary disease, comes in with a sentinel hemorrhage, just a small hemorrhage around his frontal AVM. But he wasn't a good, this is a beautiful AVM for surgery. It's right on the surface. I could probably walk one of you through doing that. But pulmonary disease, not a great candidate for anesthesia. So we actually kept him awake. And he has a morphology that's beautiful for embolization alone. You see, I think you're starting to get the sense of the diversity of these beautiful lesions. And this has a single feeder, compact nidus. We catheterized, injected it with a lava-like material called onyx. We casted it. A lot of fun to do, by the way. Don't try this at home yet, but you can cast the AVM and cure it, and you went home the next day and you got a great outcome. Didn't have to put them on the sleep. So you've got to use all the tools. So if you care about a disease, let's say you care about kidney disease, even if you're not going to do everything with kidney disease, you need to understand and study all the treatments for kidney disease. If you want to be the best cardiologist, you may not master every aspect of cardiology, but the more you learn about what your colleague down the hall does, the better you become. You don't have to do everything yourself, but you should know something so that you know when to call. The best way to collaborate, sometimes you study statistics, not because you're going to master it, but because it makes you smarter when you sit down with a statistician. How do you even talk to them? How are you going to, when you're at home reading the paper, how are you going to interpret it? You won't always have access to a statistician. Venus Stenting, this is a violinist who has this occipital AVM. We didn't want to treat her. She's a professional violinist. We didn't want to treat her. Big AVM. We would give her a visual field deficit here. She wouldn't be able to read the notes as well. But we declined. But what this AVM did over time is it continued to steal from her brain. Look what's happening to her brain. It's eating up the brain, quote unquote, because of the steal phenomenon. You see her brain atrophy there. The big brain is being robbed of blood flow. So we ultimately decided to treat her. But again, during the second embolization, she wasn't waking up. And we looked back at the, we had totally missed this. When you're looking at an x-ray, look at everything first before you look at the pathology. And we were so focused on the nidus. And this actually got me interested in the venous side. That's where there was a very interesting side of this disease. And then what about radiosurgery? Radiation is I'll just give you the bottom line. We could, again, talk about this for a couple hours. Radiosurgery is focused radiation on AVM, works well for small AVMs. So if you've got a small AVM in the thalamus or brain something you need to treat, this is a first-line treatment. Beautiful treatment. The downside is it takes 2 to 3 years to work. So somebody could rupture during that time period, but if I have a brainstem AVM, it's probably my best option. You take 3 years of risk, but then it's closed, and so you're always balancing the risk benefit. And I was going to tell you about how when I grew up as a neurosurgeon, my mentors were unipolar. We either did radiation. In fact, they're all suspicious of each other. Those who did surgery were very suspicious of those who did radiation. I decided in my career, this was some resistance, but I wanted to integrate everything. So I did, and then I took courses in radiosurgery, and I became the director of the AVM radiosurgery clinic in Chicago. Even though some of my mentors said, no, you cannot do both. You can't be an anesthesiologist and a critical care specialist. So some people integrate that to good effect. So think about making your career unique. And sometimes the most unique, look about the best restaurants in the world. They are fusion. To be a Michelin 5, you can't make the Italian dish that your grandmother made or the Colombian dish that your grandmother. You have to somehow combine Colombian with maybe French and then become with some unique twists on Colombian food. That's the only way you're going to become world famous. And so in your career, clinical or research, think about a unique angle. And by the way, on your research, don't research where the field is today, research where it's going. So part of my job as a mentor is to give you some sense where I think it's going, where the problems are, so you can stay ahead of the curve. The best researchers research where they think the field's going in 10 years. So this was just her. So this is an AVM in a high school principal. She was the director of her school in Chicago. And she had this AVM that's quite large. And this would be a good case for surgery because it's on the surface. But I decided, but she didn't want to take any risk. She was a single mother. This is why you have to know your patient. What do they do? What do they want? She wanted to take almost no risk. So we decided, and it's too big for radiation, so we did something unique. We divided into 2 AVMs. We treated half, and then 3 months later, treated the other half called stage radiosurgery. It's one of the more controversial treatments. We have the second largest experience in the world. So for AVMs where surgery isn't a good option, embolization would be terrible for this. It's too big. You will have a very high complication rate with something this size. And I just saw her for a 5-year follow-up, and the AVM is gone. So worked out nothing. So this strategy works in about half the AVM decrease. You have to have somebody who wants to be treated, good reason to treat, ideally symptomatic. It gives you another option. And if it doesn't work, this was sort of an intermediate scan where it shrunk because of radiation. The one disease where surgery after radiation is actually a good thing is AVM, because they get a little scarred, and the surgery is actually quite pleasant. Not true of other diseases. If you have a tumor that's irradiated, then it's much harder. So here it is. 5 years ago. This is just a couple weeks ago. And we get an angio where the AVM is going. This was my angio 6 years after. Let's go back to that 18-year-old. And now it's in the premotor area. For our neurologist in the room, what happens if you get a stroke in the premotor area? Is that what typically happens? Let's say you get a small stroke in the premotor area. What's the exam on the patient? Usually a weak hand, but they typically improve. So if you had to pick between a diffusion restriction hit in the premotor area versus motor, premotor is much more recoverable. If you get a motor cortex hit, your chance of recovery is much less. You can recover, but it's less likely. So this AVM is in the premotor area. Remember the mapping, the motor area. So here it is. This is just to refresh your memory. Here's the AVM. We embolized it. We offered him surgery because he's young. We wanted to give him something definitive. We were worried about that dramatic growth. So we wanted to devascularize it. We take angel hair plasticized catheters into the AVM and inject embolic material to dry it up a little bit. It's a little bit safer. Here we are at surgery. This is a grid. We've mapped the motor area behind the AVM. So I don't believe the MRI 100%. I mapped it electrically. You can put a grid on the brain, and my neurophysiologist can tell me, yes, you're in front of motor area. So I confirm everything physiologically. And so here we are, and you open up the subarachnoid space, and the AVM is an ice cream on a cone. It's a bowl of spaghetti. In that bowl of spaghetti, there's a cone, and if you unravel it, you could wind up from a bowl of spaghetti to a ice cream on a cone, which you're going to see here in a minute. But you have to unravel it, kind of like when my daughter used to ask me to unravel her necklace. You have to be patient, and so here we're opening up the subarachnoid space, working circumferentially around. I apologize. Sorry. I pressed the wrong button here. Okay, 1 second. Okay, so here, this is the arachnoid. So we're going to open up the arachnoid. So when I was junior, this to me would be like daunting. What am I going to do here? So what you do is you open up the subarachnoid space. These are your gifts. So a surgeon, a neurosurgeon, the subarachnoid space is a gift from Mother Nature. So we open up these spaces. That's where you're going to find a lot of the feeders. So we systematically and patiently, like trimming a bonsai tree, for those of you who watch Karate Kid, and we're going to systematically be like an architect, be like an archaeologist, and sometimes they can spend 5 years to find a dinosaur bone. I can spend 12 hours. That's nothing compared to the archaeologist. So here we are systematically devascularizing it, and here we're working circumferentially to leave normal brain and devascularize, taking away feeders one at a time under high magnification using forceps. And here, eventually, we start to win. And you're monitoring the draining vein. If you noticed earlier, this was bright red. It's starting to turn blue. This is for me a thermometer of how things are going. And now as we get deeper, we're going to have very fragile feeders that require very tiny clips. You basically, with your suction dial way down, you can bring that suction, almost talk to it. You can come to me. You can have a dance in your sucker. You have to have a sucker turned way down. And it sits there. Because if you try to fragile it, it's not going to fragile it. It's going to snap back in the white matter. You keep chasing it. And you can come to me, you entice it to come into suction, just a little bit of suction. And then with your right hand, you don't take your eyes off, your good nerves, and do the right clip. Otherwise, you can be doing damage for hours. So that's a skill that you'll have to learn, and I'd love to teach you. So now we're working circumferentially, and now the AVM has been disconnected and the vein turns black. What this video is missing is I wanted to show you that stream in a cone, maybe the next week. That was cut out. Post-op angio. He woke up with a little bit of hand weakness. 2 weeks later, completely intact, including fine motor function. So premotor area work tends to recover very well. If this same AVM was in motor cortex, I probably would have used radiation. But I wanted to give this 18-year-old a chance to have, because of radiation, the result is not guaranteed. It could rupture during those 2-3 years. This is why we chose this approach. This patient was an opera singer. She had been a one-hit wonder. I won't tell you the song because I don't want to violate HIPAA. She had one hit. Her career didn't take off. She went into opera. She had a great Italian teacher who I had to deal with. And she told me she was very promising. I don't know anything about opera, but she told me she was very promising. She had a seizure, and she has an AVM and Wernicke's. The AVM is actually tiny. What you're seeing here is all the black. This is the hemosiderin stain. Now we have a dilemma. A woman who builds up tremendous pressure with this pressure-dependent lesion in her Wernicke's area had a seizure. She wants to perform internationally. Is this the end of my career? And if I treat it with radiation, I'm going to take 3 years off my career. I don't want to go on stage with this thing sitting there, this AVM. And if I have another seizure on stage, what's going to happen then? So she wanted surgery, and I'm thinking, oh my God, I'm going to take an opera singer. I'm going to end my career. I'm going to have to open a coffee shop in Phoenix. I'm going to take this woman's career. She's famous, and I'm going to kill her career because I'm going to be the surgeon who operated in Wernicke's area, the Wernicke killer. And so, okay, so we're going to map her brain. Now, it turns out, here's another example of knowledge. Most of our functional MRI mapping for 100 years was move your hand, motor area. Say 1, 2, 3, Broca's. Now, what do you like to do for a living? Oh, you're a journalist. Can you imagine interviewing the president of Colombia? You know how many centers light up in the brain? Dozens. We don't even know what they're doing. Now, we imagined her. We didn't want her singing opera in the MR singing. We tell her, imagine singing your favorite piece. Her head lit up like a Christmas tree. So now I'm a soldier. I'm an Air Force pilot going into an area with a bunch of SAM missiles. We don't fully understand the mapping. Some of the missiles could be buried underground, some of them above ground. How do I achieve my mission of disconnecting this lesion? I need to basically walk an alligator-infested pool to grab the diamond. And add to that complexity, the AVM is actually quite small. I'll show it to you in a minute. There's a lot of tissue affected by hemosiderin. So if you're going to look at this not just as an AVM surgery, she doesn't want to have any more seizures. So you want to leave hemosiderin behind? How do you make an animal model of seizure? Inject iron into the brain of an animal. You will create a seizure model. Make sure you get approval for that from your dean. But it is one way to create a seizure model. So my job for her, I have to be honest, what can I deliver? Cure the AVM and walk away? What about the hemosiderin? Have I achieved the full job? And what is the natural history of hemosiderin? Again, we don't really know. If you look at outcome from cavernoma surgery in the brain in patients of hemosiderin, high cure rates of seizures because with cavernoma, surgeons have been aggressive. But with AVMs, people are less aggressive in surrounding tissue, so we don't actually know. So I had to form a hypothesis that was unique to her. And on top of that, I didn't trust my functional imaging. So here's my functional imaging. This is language draped around. These are the alligators in the pool. The diamond is sitting at the bottom of the pool. This is the AVM here, and this is all the hemosiderin. And here's the angiogram. It's actually a very nice, simple, small AVM, drains into Labé. And so it's not a very big AVM. Now, could you embolize this for sure? Yes, but you've left the hemosiderin. So this is another example where you have to be smart. My uncle, while I think trying to harass me, always say, see these up here? What is that called? Frontal lobe? Use it. That was him putting me down because he saw me doing something stupid. And so that's a line I won't forget from my uncle. I always feel my uncle telling me to use it. And so here's the AVM. Sorry, this is stuck. Oh, there we go. This is the AVM. Right in here. So our group was the first, I believe, way up, laser that all the potential Montreal hundreds of epilepsy, murder and others. One of the first things you don't like that to be big surgery. So here we are at surgery. We've actually opened up more of what we need to see, because I wanted to map the brain. Then we cross the brain out. Here we're just putting up motion control to stimulate and give that function a rest. We're having a speech here. So actually, 1, 2, 3, roll raising. And if I see that area that stop, I know that here we're mapping the brain surgery. We're watching. We're still doing like you're sitting across the seizures. Take our time, it takes a little time. And here's our cognitive psychology of the ICAD. Testing not just simple stuff, but complex. We have to talk about that. But here, these are all areas we mapped. Here's the AVM, relatively quiet. The alligators are all here. It's part of the pool. The diamonds here. They can jump into that part of the pool if I'm slick enough to do it. And here, these are all the functions we've mapped. Now we can map them, right? At least on the surface, we don't have the depth. And here we're now dissecting the AVM 3. This is the draining vein here. We're going to trimming a bond wedge. Sometimes an artery can come through. Let's say consider. I can give up here, but then I'm going to go on and let's say you're the you don't want to feel tough. You have to. So here, this is the vessel we preserved. Now these little stumps are disconnected from the AVM. A lot of fun to do that. You know what to do. So here, this is the ice cream. So now, imagine this is the ice cream. That's the draining vein. The AVM is an aggressive entity. But the more you devascularize it, it goes from a wolf to a puppy. And here that's the ice cream, and the draining vein is turning red. The red is high pressure. Pressure is dropping. So 126 salt, 90, 87, 60. And if you put that vein earlier, these are all. They're not a great fit. Sorry, the projection is fast, but they're the screen. Everything's going to tank. We have the nidus and the draining veins. Oh, there it is. The ice cream. This is all tangled up. Okay. And then with monitoring for speech recognition, some of the white matter that's nerve right because of white matter. We'll monitor this receptive and keep up cigarette state brain. That's like she actually performed the consult trauma 4 months after surgery. She's been out of the OR. I don't know if I've seen it 3 months. Out of the OR, she was sitting. I was so terrified that she was going to fall brain test. Then when we talked about we had BBC 7 News, no CNN. It was a Chicago news station. One man, one woman show. Unbelievable. No, downward pressure, massive. Nothing stuff good, and that's probably That sounded like I couldn't end my career. So, let's see a couple more cases. We got time. So, this next case is about what I call night of living dead. We all want to be superheroes. That's why superheroes are so. People think it's superheroes. They can tell you, we're still going back to the theater. We want to believe it. So the chance that you medical school or a doctor or superhero, you'll come in dead. Because it's fast. You have a burning AVM, midline cerebellum. Guns. It's called a nursing home. Anytime you have bring up if you think of your fast enough, you can turn it around. And so this patient came in with this cerebellar hemorrhage. A very poor exam, essentially almost brain, not reactive pupils, and most doctors are not experienced, even neurosurgeons are focused on traffic and thinking how to get there in the hospital. But this is the kind of patient where you put the tape on, fly down to the ER and say, we're going to the OR right now. And you create some room, you don't even have to talk to the AVM, just create some room, and go right to the agent. Seal it, take it back to the ICU, put your brain to not. I have maybe a dozen patients that are getting dead, we're not back to it. But they're fast. Now we're set the family meeting, this is all for the other doctors, you have to move. So here we are. Here's the rupture site. So after we did the craniectomy, we counted, this is the flow-related aneurysm. This was the ticket time bomb, the rupture again. We just catheterized the angel circumference catheter. And then we coiled it. We went back to XU, let our nerve prepare to do the magic. They create that moment to seal the rupture site. And that's very good, basically. We had identical case. Identical case to one of my favorite diseases. And so here's the coil map. The platinum coil sitting on the rupture site. About 3 million. Not that hard to do. And now we've sealed the rupture sites. Now it's like the AVM still built. We'll shoot that down a little bit. That can't be covered. It's got a little bit covered. 3 months later, this is the most reactive in small group. Things like so this is another one where it's your female and an AVM that I really not want in my mental. At this AVM, this is big AVM, it's right in the middle of we saw a question note along 32. Vice President. No, that means you're not supposed to. And we said, no, we don't need to finish the room. Next year, she'll do a week. Nah, it's look, we're going to do more stuff. Every year, she takes a little bit. Look what's happening. The AVM is eating the brain. It's a little brain fall. And the motor goes in a wheelchair. And vice for the health. I think you guys are conservative. We're not even watching every year. 32 shows. Okay. Maybe if we utilize a couple sessions, inject on there. That's the alligator that move or go up to the files. So first embolization was great. We all high five each other. All the vice presidents. And then here it is. After the second embolization, she got to the ICU. And before the scan, she not a sign of difference, that's a sign of big trouble. What's the mortality of this here? 90%. When I was a resident of these patients, they kept there all night. But catheter, the brain, the recast the measure of the mortality of 90%. And we have a rupture AVM, which is rupture. So what are we going to do? We can't drain this. And operations have proven to be very destructive. So we're back to the industry. Still the ruptures that we found right here. Still in the blue violet. And then took it back to this and started drinking TPA. And so here we're drinking TPA. It's a day 1, day 3, day 4, day 5, day 6, day 7, day 19. She lived, went on to have surgery. One up with a heavy paralysis, the function walking, which I don't recount she should have done. Here we have to work with critical care, anesthesia, ICU, embolization, surgery. If you don't have a cohesive team, you're going to lose this battle. You're not forgot the news about how some army organization can't coordinate to all the units. Any without it, you have to bring the best of the organization to get to the ego side. And so she wanted to really quite well. They need to be a shot, which is really is always scary. So this is another beautiful story. Where do you want to get that one more with this? Oh, boy, this is a question. Yeah, you know, we don't, so the guideline itself, it's a grade 5 AVM, minimally symptomatic. Everything we don't from the literature, we don't treat. So you're going off of a limb. You have to be careful not to, we don't get too anything. Well, one patient is happening, we have 5 other patients. So you're asking a brilliant question. It's an knowledge question. Every knowledge gap is not true. I don't have to answer your question. We have that. I'm going to have, first of all, we need to have artificial intelligence based on my AI study millions of scanned patients. Look out, this AVM is a function. I don't have to live through that. So rely on this. It's perfect. One day, really interesting. Wax ultra clean from carbon that holds the brain perfect. Kids are getting scared. Those looking at something just looking back at the bottom. So what we consider as cutting edge, exciting today, don't ever astronomer all the time wants to be a cosmic. Can't go back to home. We don't know it. We're not sophisticated melody. Doesn't mean we're not, not like how I feel for humble confidence. Be confident, train the best medical school in the world. Not one of the other, not the real sport. Humble come to it. You're close enough. You're not going to feel that. You're going to be a firefighter so scared of the fire that you're going to. Now, if you're too much of a cowboy, ego belongs with ego with it. Ego belongs with the engine. We all have ego. Ego has no role. But it's the right thing to have an engine. Understand how you can have it. Because it's the right part of your soul. Vibes are efficient. You want to apply them. That's okay. It has to be the drive of the engine. This is how it happens. So this is a beautiful gift. Poor parents, lovely parents. You know, when a 4 year something was two parents, they have no one else in their life. You know that they suffer. And she suffered with seizures, progressive paralysis. CAT scan, what's all this darker area? Not a stroke, it's all white. Not multiple stroke. What's going on there? So we did an MRI. Now you now know more than most North
longer difficult. Right? But look at that white matter. Not only is there loss of brain tissue, look at all that white matter signal. What's happening? I should put my hand around on the part of it. This AVM is skills of the white matter. Now, this AVM is not huge. It has complications, very big dilating veins right under the dura. So you can surgery. You're going to give a high chance of injury on the AVM. And that tissue, I was really worried about that tissue around the AVM. How's it? If I just remove this, you could do okay, but if I can't stop the bleeding, I could have to chase meters. It could be perforation, but without any injury. And so I thought with this AVM, will be easy to treat. It would slowly kill it. And so here's the AVM. Look at all that brain edema and shit. So we did serial embolization. This is the MRI. The functional one. This is the hand area, not too far from the AVM. And then we're gonna. This is the white here, the cortical spinal tract. And here's the AVM. It's not on a simple AVM. It's not as big as all the others. So we can tackle surgery techniques on vertical position. And here we are. This is just different runs of the AVM. This is the posterior circulation run. It's applied by the FCA, PCA, and PCA. So we do embolization. We devascularize it a bit. But you don't have to vascularize it completely. Otherwise, it's pure killer. So be gentle. And so we're going to do that in stages. And here's a microcatheter. We've driven this all the way up to the distal vessel. These are embolized catheters. And we embolize this. Now, look what happened. Look at what happened. This is after embolization. This is actually an incredible case. I've talked for decades about this embolization normalizing hemodynamics. This is one of the cases where this happened. So now I felt a little more comfortable operating the box. Looks, really worried that my craniality alone could explode. When that things happen, I was very vulnerable. People, oh my God, disaster, the number wants to be I wanted to simulate the operation. I calmed my nerves. So now we've built an avatar for all my music and avatar. It actually simulates the operation. This is the vein that's coming to the surface. Just me opening the dome, like basically planting my vertebral around this big venous barrier. Here's the nidus. I'm arcade flying around the AVM. Now I'm getting to know the AVM. And it's just like the medieval procedure. The more we know about the energy, the better your plan will be. And so here I'm looking at this again from FDA. And then we're going to bring that data to the wall. And then we'll walk with the bring that data set. Merge. What am I doing now? Data. Merge with the patient. Now you're working with this reality environment. Bringing the best imaging, best the data together with the patient. This is before my AR patient, but since this case, we now bring that data and superimpose our phase in around. So here this is ICG angiography. That's actually a form of augmented reality. Where we're taking the angiographic data and superimpose it. Remember the techniques we now know that we're all now master subretinal space. A little more complicated in the other cases. The principle was the same. One thing I want to mention is worry about the process now. Affect your process, your outcome will be good. Spend more time. Most doctors spend time on outcome, which is good, but process is very, most doctors ignore process. So keep the process consistent. And so here we're disconnecting it. There's two draining veins, one that goes this way, one that goes this way, from all the acid on this mass. At some point when we drop the venous pressure, I can take one of the veins without rupture. Here we're working below it. We have this AVM ready. My nurses have lined up, children. There we just off the flip side. That's a little hard to learn, but I can teach you. And so there we're applying a clip there. And now we went from a angry pack of wolves up to the puppies. The case where your agent is more scared of you than you are. Again, one of them. We drive past the friction democracy, but you kind of have to say there's hold the truth to be able to siege out of the water. Then you don't even need a war. Other than that, this is more now. Let's see here, that's the ice cream all done. She mentioned that the seizure free now. She's regained her motor function, and I convinced her to put on. There's a lot of work that we do. But I work with her parents, lovely parents, and now it's starting to people. That's supposed to be great. But this needed a strategy, strategic plan. Just look at that monopolize way too much. I'm not just get to the end here. I'm sure we will cases. That's a case we did a couple months ago where we superimposed the avatar onto the patient. So we could work in a blended environment. So the robots would be our part. Digital and reality are blend. That's what you're going to live it. So we'll just take 5 minutes about my lab and innovation. So 5 years I started a 3D print lab because as a student at your state, I found it really hard. People group that they had more non-strengthful, more soft-based design. It's probably, yeah, there's probably a lot of questions built into your question. Depending on how you did it. Most patients who have shown you yeah, they don't have more time. So I do want to, you have to talk to more details. They have more language for questions to talk about. So at your stage, I found that it talks about watching my mentor. And I was watching kind of second again. And awesome. So I thought what I need to do is better understand the problem with healthcare surgery is that we're doing two-dimensional work, learning from two-dimensional text. Now I thought that is something that well, you're going to be a basketball star, first star, or soccer star, first read the book also. Then we're going to show you the two-dimensional map, how to place that. Once you master all this, you go on the field. Those books and avatars, you fill the holographic environment. That's the soccer team of the world. We'll play that holographic from day one. So all my friends found, I have this, get the video to show you. So start with 3D printing. So this was a complex again I saw. I did the hold it in my hand. That's where it used to be the halfway through a case, you get the most scared of me. Now I use that curve to the left. Now before surgery, I know what rupture. I know what it's about. Or in my mind, know where to go. I know every alligator pool. I know which direction they're going. I know how long it takes to get the time. Let me check that. Versus the complicated full flow. Study preparing is part of the success. So then we went out to 3D printing the holography. So now we published the clinic, and I found it was making my patients more alive. Bring the patients to the present. So we started building hologram, bring the hologram to the clinic, and start talking about the hologram. And then, this is robotics. So the future where we have robotics research program. Again, my dream is to have a robot. My dream is to telehealth and that. But so then we have integrating And so now we put ambulances in Arizona with telehealth. So that if an AVM ruptures, we move that survival code. We can make a diagnosis earlier. This is just an example that there's an office case where we did the surgery and here is a short review of the reality. I showed you earlier. So this was again, just to show you where we're going, and so in your generation, think about what we can do now. Look at the start. We go through nose. We get right through the arteries. We get through the radiation. I think what's happening in almost any brain has imagine your generation. Imagine somebody has a stroke of what we thought it takes an hour. It takes 3 blocks away from your life. Your head's on display, have the animal inject something with them heart, and navigate the supplement to the brain. Capture the blood clot, cause a stroke. Based on, so we're going to move to another country. So after no longer severe construction, this construction is one that we prefer. On that note, I can apply some time. There are, we haven't done, we're talking today, so an animal, it can affect any antibody, the question is taking that we approve. So, if I was going to do a PhD today, I would go find company, do a PhD on that. Imagine if you could do what's important about renewables, molecular signature, it's like structure and somehow magnetic interference that has nothing to do with biology. So we think our point is merely the tip of the iceberg. It's kind of like the captain of the defense. Oh, we're about a huge ship. Because they didn't have radar. No one does. Beware of the partial blind careful of what we're blind to. What we don't know is which animal to do. Other questions? I'm sorry. Yeah, so that's a tough question. So asymptomatic, we'll do an angiogram and do annually. The biggest consultation, not the AVM. Let's see the grade 4 and 5. Probably grade 6. Then you have to get some bridge to teacher. Where is the what is around how the teacher passes. And the office of part of it. I didn't talk about virtual development. Every question you got to ask. you have to say 3, 4, 5, what's the ball? Then you're on a you don't know as much about it. Very first patients very very I have a really summer home. You know, we should think of the 9. You're ready to get back to the parents, the shovel, lost the job, lost the car, lost the function, developing anxiety, the rules. I have a I feel and I think they're new. It's off the migration. Her life was destroyed. So after that case, I found a friend of a friend who's a psychologist. Now, the most first nurse. And so she's like, you know, the most that bring to our families. What is American? Is it not to us hard. But I go for example, I hear the question, if that's all for years of it. So I wonder if one of these in the team, like he has to have a psychologist. He has to think about what am I doing? The last one that she spouse of the world, their patient, in the midst of their treatment. Complicated. Who's around?